There are three conversations happening about GLP-1 drugs right now. One is on TikTok. It looks like effortless transformation. One is in academic journals. It looks nothing like TikTok. The third one, the one almost nobody is having, is about what happens when you stop taking them. I'm going to give you all three. Because the GLP-1 story is not as simple as the people selling it want you to believe. And it's not as dangerous as the people afraid of it want you to believe either. The truth is somewhere more complicated, more interesting. Opening graphic, 3 columns. What TikTok says, what the studies say, what nobody mentions. Let's start with what GLP-1 medications actually are. GLP-1 stands for glucagon-like peptide 1. It's a hormone your body produces naturally after eating. Diagram. Simple molecular animation, GLP-1 hormone pathway from gut to brain when you eat. Your gut releases GLP-1. That hormone travels to your brain and signals satiety. It slows gastric emptying. It stimulates insulin release. It suppresses glucagon. In people with type 2 diabetes and obesity, this system is dysregulated. The signal is weaker. The brain doesn't receive adequate satiety feedback. Diagram. Comparison. Normal GLP-1 signaling versus dysregulated signaling in obesity. GLP-1 receptor agonists drugs like Semaglutide, Ozempic, Wegovy, tirzepatide, Mounjaro, Zepbound, and liraglutide, Saxenda mimic and amplify this hormonal signal. They don't burn fat directly. They don't speed metabolism in the way most people imagine. They make your brain think you've eaten enough. They do it with a potency the natural hormone can't match. This is why people on these medications eat less without consciously trying to restrict calories. The restriction is happening at the neurological level. Diagram. Brain satiety centers with and without GLP-1 agonist activation. That's the mechanism. Now let's talk about what the data actually shows. The SURMOUNT-1 trial, published in the New England Journal of Medicine, followed participants on tirzepatide for 72 weeks. On the highest dose, participants lost an average of 22.5% of their body weight. Data graphic, clinical trial results, clean bar chart, blue number 1976D2 bars on white background. That's not a modest effect. That's surgical territory. The STEP trials for semaglutide showed average weight loss of approximately 15% of body weight at the highest, proved dose over 68 weeks. For context, behavioral interventions alone, diet and exercise programs, typically produce 3 to 5% sustained weight loss in clinical settings. If you've been watching Lean Protocol and want more breakdowns like this every week, hit subscribe. I cover what the research actually says, nothing else. Data comparison graphic, GLP-1 trial results. VAs. Behavioral interventions, teal number 00897 line versus charcoal baseline. These numbers are real. They're in peer-reviewed journals. They've been replicated across multiple trials. The people saying GLP-1 drugs don't work are wrong. But here's where the TikTok narrative diverges sharply from the clinical picture, because the studies that show 15 to 22% weight loss. They also show what happens when participants stop the medication. Data graphic, weight regain post, discontinuation, line chart, red trend line returning toward baseline. The STEP 1 extension study followed participants after stopping semaglutide. Within 1 year of discontinuation, most of the weight came back. Average weight regain, approximately 2/3 of what was lost. 2/3. This is not a side effect. This is not a failure of willpower. This is the pharmacology working exactly as designed. GLP-1 agonists suppress appetite by maintaining an elevated hormonal signal. When you remove the drug, the signal drops. The appetite returns.
How the system reverts.
Diagram. GLP-1. Drug effect timeline. Gradual onset. Maintained effect during treatment. Decline post-discontinuation. The clinical implication is stark. These medications appear to require indefinite use to maintain their effects for most patients. For patients with severe obesity and type 2 diabetes, this may be an acceptable trade-off. The cardiovascular data, the SELECT trial showed semaglutide reduced major cardiovascular events by 20% in high-risk patients. That's a meaningful clinical benefit that extends beyond weight loss. Data graphic. SELECT trial cardiovascular outcomes to 20% reduction highlighted in teal. But for someone without metabolic disease who is looking to lose 20 pounds for a wedding, the risk-benefit calculation looks completely different. Drop a comment below. Has your doctor ever walked you through the discontinuation data before prescribing? I genuinely want to know how common this conversation actually is. Diagnostic diagram, patient population breakdown, who benefits most from GLP-1 drugs, according to current evidence? Let's talk about side effects, because TikTok has created two equally distorted narratives here. The first, GLP-1 drugs are completely safe. The side effects are minor. This is just progress. The second, GLP-1 drugs cause thyroid cancer, pancreatitis, Ozempic face, and muscle wasting. Both of these are incomplete. Split graphic. Confirmed side effects versus exaggerated, unproven claims. Clinical data behind each, what the evidence actually shows. Gastrointestinal side effects. Nausea, vomiting, diarrhea. Constipation affect a significant portion of users, particularly in the first weeks of treatment. In SURMOUNT-1, over 80% of participants reported at least one GI adverse event. Most are transient, some cause discontinuation. Gastroparesis, delayed stomach emptying, has been flagged as a concern. Several case reports exist. The pharmacokinetics of the drug slow gastric motility by design, and in some individuals this effect appears more pronounced and persistent than expected. Diagram. Gastric motility animation, normal versus GLP-1 slowed, gastric emptying. Thyroid cancer, the signal is real in rodent studies. The relevance to humans is genuinely uncertain. Semaglutide is contraindicated in patients with a personal or family history of medullary thyroid carcinoma. This is not a theoretical precaution. Ozempic face. The facial volume loss associated with rapid weight loss on GLP-1 drugs is real, but misattributed. It's not a drug effect, it's a weight loss effect. Rapid weight loss from any cause produces similar facial changes. Clinical diagram. Fat distribution changes with rapid versus gradual weight loss. The muscle loss concern is legitimate and underappreciated. DEXA scan data from several trials shows a meaningful proportion of weight lost on GLP-1 drugs is lean mass, not fat mass. In some analyses, up to 25 to 30% of total weight lost is lean tissue. This has significant implications for long-term metabolic health. Muscle is metabolically active tissue. Losing it makes long-term weight maintenance harder, not easier. The protocols that produce the best outcomes combine GLP-1 medications with progressive resistance training and adequate protein intake. That evidence is building, but not yet definitive. Data graphic. Body composition changes. GLP-1 alone versus GLP-1 plus resistance training. Bar comparison. Here's the larger picture that gets lost in the social media noise. 1 billion people worldwide live with obesity. The disease burden, cardiovascular disease, type 2 diabetes, certain cancers, reduced lifespan, is enormous. Data graphic. Global obesity statistics. Clean infographic. Charcoal and blue palette for decades. The medical community had essentially nothing effective to offer patients with severe obesity beyond surgery. Behavioral interventions produced modest results. Previous pharmacotherapies were either ineffective or dangerous. GLP-1 agonists represent a genuine pharmacological breakthrough. They work in ways previous drugs did not. The evidence is solid. The question is not whether they work. They do. The questions are, who should use them, for how long? At what cost, financially and physiologically, and what needs to happen in parallel? Decision framework graphic, evidence-based patient selection criteria, who benefits most from GLP-1 medications. The access barrier is also real. A monthly Wegovy prescription can cost over $1,300 out of pocket in the United States. Insurance coverage is inconsistent. The patients most likely to benefit medically, those with severe obesity and metabolic disease in lower income brackets, are often the least able to access the drug. Data graphic. GLP-1 cost versus income bracket access, inequality visualization meanwhile. The off-label use market, healthy weight individuals taking GLP-1 drugs for mild cosmetic weight loss, is growing rapidly on social media. This is where the risk-benefit balance is least favorable and the prescribing standards are loosest. If you found this breakdown useful, subscribe to Lean Protocol. I do this kind of evidence breakdown every week. No supplements to sell, no program to push, just the data. Synthesis graphic. Evidence summary. What we know. What we don't know. What the research is building toward. What the research tells us right now. GLP-1 drugs produce significant weight loss in clinical settings. The effect is real and large. The weight returns when the drug stops. For most patients, this implies indefinite use. The side effect profile is meaningful but manageable for appropriate patients. The cardiovascular data in higher-risk populations is genuinely impressive. The muscle loss data deserves far more attention than it currently receives. The cost and access inequity is a public health problem, not just a market inconvenience. And the long-term data, what happens at 5 years, 10 years, with continuous use, simply doesn't exist yet. These drugs have been in widespread use for a relatively short period. We are conducting the long-term trial in real time. Final data graphic: GLP-1 evidence quality rating by outcome. Strong evidence, emerging evidence, unknown. TikTok wants you to believe this is simple. Critics of the drugs want you to believe it's dangerous. Pharma wants you to believe it's the solution. The actual science says this is a powerful tool with a specific patient population where it clearly makes sense. Significant open questions for everyone else, and a cost structure that may be one of the most consequential public health problems of the decade. That's a less viral story, but it's the right one. If you want to go deeper into the muscle loss data specifically, because that's the piece most people are missing, I linked the key studies in the description. Read them, not just the abstracts. Drop a comment with one thing from this video that changed how you think about GLP-1 drugs. I read everything.